Hi, everybody. We'll go ahead and get started to be on time. Thank you so much for coming. Today's didactic topic is building and sustaining peer support programs. This is a didactic sponsored by the SAEM Wellness Committee. We have no final financial interests or disclosures. And I'd like to start off by some introductions. My name is Vicki Zoe. I'm from the University of Vermont, and I will be your moderator for today's session.
I'm Laura McPeak. I'm also from the University of Vermont.
Can tell them their role.
Can you hear us?
Oh,
You can
sure.
hear us.
My role is I'm the Director of Provider Wellbeing and Organizational Culture for the Department of Emergency Medicine.
Hello, I'm Andrew Wong. I'm from UC Davis, and I'm a department wellness champion as well as a peer supporter.
Hi, everybody. I'm Sadia Akhtar, and I am at the Icahn School of Medicine at Mount Sinai in New York City. I'm the Senior Associate Dean for GME Wellbeing for our health system.
Rita Manfredi, George Washington University in our nation's capital. I am one of the editors of the online book From Self to System, one of our wellness books for emergency physicians, as well as one of the authors of the Well Workplace Clinical Policy.
Hi, I'm Susie Bentley. I'm from New York City Health and Hospitals Elmhurst in New York City, and I'm the Chief Wellness Officer there and run our peer support program.
I'm Hannah Chasen at Brown University. I'm the director of the SIPS Peer Support Program.
And I'm Eli Alvarez, Stanford's Director of Wellbeing. Relevant to this, I'm the Director of the Peer Support Program for our institution.
So as you guys know,
I think we're competing if one of them is on. So if that's number one,
Maybe we should just pass that mic.
can you hear me now? Great. So as you can see, we have a powerhouse panel for today. And this keeps cutting out.
Here, so take this one.
Yeah. Only one can work. Only one can work.
Apologies for technical difficulties. We'll move on. So with our powerhouse panel today, we will be going over the following learning objectives. We're going to analyze the role of a peer support program, potentially at your institution, and the key components of a successful program. We're going to outline the steps for implementing a peer support program and discussing what specific training and resources are needed. And finally, we're going to explore strategies for promoting and sustaining a peer support program at your institution. Here, if you'd like to scan, this is a QR code, which is going to have our references for today's talk, as well as some important resources and areas for support. We'll give you a few seconds to scan that if needed, and I'll bring you to a Google Doc. Hopefully everybody can access that. Still a few in the back scanning. We overall good? Great, and that'll show up again at the very end of the presentation in case you missed it. So to just provide a little bit of introduction, we all know in emergency medicine that it's really important that we do a teamwork sort of specialty, that we support our peers in crucial times of difficulty, and we really recognize the importance of camaraderie and mutual support. But at the same time, I think we often feel that we feel isolated despite working alongside our amazing colleagues. We feel like nobody understands the weight of the pressures we deal with, the difficult cases that we carry with us every day after every shift. After the COVID-19 pandemic, there were significantly elevated levels of anxiety, depression, suicide risk, and burnout. And in this 2020 study from ASAP, they found that 87% of EM physicians actually reported feeling more stress since the start of COVID-19, and about 50% of EM physicians felt that they couldn't comfortably seek mental health care treatment. This is really where peer support programs can come in. They're a program that can provide mutual support for our colleagues in a very private way. Peer supporters are trained clinicians that can provide support during times of clinical, professional, or even personal challenges. So this is not necessarily limited to difficult patient cases. We're going to talk about today what resources and perspectives you can use at your institutions for providing these formal and also informal connections among your peers. These peer support programs exist in a lot of different formats. They can exist on a one-on-one basis between two colleagues. There's also group peer support. I'd like to sort of just start off with a brief poll from the audience. Who at their institution has some form of a peer support program where they are, either in their department or on the institutional level? So that's pretty good.
We're done.
That's true. Yeah, we have nothing to teach anymore. But that's not completely true, as you all know. Now that we reviewed a little bit of background on peer support programs, I'd like to ask our panel our first question. What are the various models for peer support programs at your different institutions? And as you could tell, we have panelists from all over the country, from all different types of programs and departments.
So emergency physician to emergency physician peer support is very, very well received. And we've known from studies that emergency physicians want to speak to other emergency physicians when they're having problems or they're under stress. So that is sort of the gold standard, but that's only one of the many models that you can use for your peer support. And we'd like to get some insight from the audience about what your peer support programs are like. So you can continue that model, emergency physician to emergency physician in one department. But if there's a question or a problem with anonymity, you might want to partner with a sister institution on the other side of town. So those people could get trained as being peer supporters, and then they could support your people who might need it, and vice versa. So that's one model. Other models are you just go ahead and cover your whole department. So APPs, doctors, residents, and then you can even expand it to bigger than that. You can go and add nurses, techs, respiratory therapists, so that you're covering your whole department. There's even another model, and that is you can cover the whole hospital. And anybody know what the next model is? You can cover the whole system. And then there is another model I wanted to tell you about, which is the national model, where peer supporters are trained. And then what they do is they take that information back to wherever they may be and set it up in whatever way is very unique to their system.
So I'm just going to talk for a second about what we have at Brown. We have the SIPS program, so it's called Critically Important Peer Support. And we are focused just on the emergency department. Can you hear me? Oh, there you go. So we're just on the focused on the emergency medicine department, but we have APPs, residents, as well as attendings that are involved in our program. And so we try and pair peers with people of either similar levels of training or experience on the job. And so like we'd pair APPs with APPs, residents of similar training levels, and attendings of similar times out, and just try and match somebody with who we would think they would kind of get along with.
At UC Davis, we have the Support You Peer Support Program. It is an institution-wide program that consists of both clinical as well provides services for clinical folks as well as even non-clinical folks like EVS and transporters. We have around 1,100 peer supporters in our system. And we offer both one-on-one sessions as well as group sessions offering emotional support as well as connections to other resources if it's needed.
Yeah, so I think similar at Sinai, we're a big health system. We have like 8 different hospital sites, and the peer-to-peer program that we have is called iCare, and that's really more for like clinical issues that are coming up. If there's been a bad outcome, there will be folks that will reach out to the providers, but also I think, you know, as what you were speaking to about the non-clinical folks, like I think sometimes we forget that even those people are, you know, involved in issues that may happen. Just to give you a quick example, it could be someone from environmental services that, you know, witnessed something that was terrible. They're cleaning up the rooms. They could have also been impacted. And so I think thinking about it from an institutional level, you can definitely encompass care and services. And like you were saying, the key thing is to like connect those individuals to like other mental health resources if they're needed.
Yeah, it's a really important point to think about, Sadia, that on an institutional level, that there's really people from all different jobs, perspectives, that really are impacted by difficult cases, just like we are as EM physicians. I'd like to move on to our next question for our panel. So, how do we start the process of implementing a really well organized and effective peer support program at our various institutions, especially with all these different models that we talked about?
So years ago, a female ENT surgeon from Brigham and Women's, Joe Shapiro, put together one of the first. I see heads shaking in the audience. Put together one of the first peer support programs for physicians in medicine, and so they got it all set up, and there they were waiting for physicians to come to them, and they discovered that physicians weren't going to present themselves and that they had to go to the physicians first. She wrote a very evidence-based paper and outlined exact steps on how to have this peer-to-peer conversation, which I'd love to hear from my panelists if they've implemented those steps. And those steps are real simple. The first step is just invite the person who might be suffering to see if they want to talk. And then the second step is to listen to what they say and listen actively. And then you've got to be good at this. Reframe the situation for them so they can sort of get a better perspective. And then what you do together is sort of try and make sense of the situation and then brainstorm on how to cope, and maybe even then what your job is to give resources to that person so that they can take it, and if they need further therapeutics, they can do that.
Joe Shapiro was actually came and helped us do one of our first trainings when Dr. McPeak was setting up the program at Brown. But we have implemented a lot of those steps in bringing people in. We've tried to really lower the threshold for presentation and trying to create it as kind of an expectation within our own department that people are looking out for each other and that this is not some kind of sign of weakness, but it's a, it should be expected that we're all looking out for each other. And if we have a hard case or just are getting stressed by the job, that somebody's looking out and reaching out. And so we've tried to really lower the threshold for activating a peer supporter, and people can activate on themselves, or I think the residents have really done a good job in looking out for each other. I think it's just kind of easier within the resident culture, but it's definitely been built in more as an accepted part of the culture amongst them, that you're looking for people who might benefit from this. And so just a brief description of our program. When we recruit peer supporters, we open it up to everybody in the department. So people can nominate themselves if they feel like they would like to be in that role, or people can nominate colleagues that they feel like would be a good in that role. And then everyone completes a 4-hour training that we had yearly. And we go through kind of Joe Shapiro's model for how to do peer supporting and do a little bit of like simulation, talk with each other and practice a peer support session. And then we do that yearly, so people get new peer supporters can learn that model, and then people can get kind of a refresher.
At UC Davis, we have periodic recruitments institution-wide to train peer supporters, but even within the emergency department, we actually have, as part of our residency, a didactic program, quarterly professional practice of medicine sessions. And one of those sessions that we hold once a year is on peer support. And so actually for a group of residents, we train them how to do peer support. And one of the things that we emphasize, the principles that we follow are part of the what is outlined in psychological first aid. And so it's a lot about active listening, a lot about not telling the person what to do, but helping them reflect, explore ways in terms of finding productive coping mechanisms, but all through having conversations, mainly asking questions to help guide them through to be able to get to where they need to be.
Andrew, I think that's a really good point. And I think a lot of peer support is it's someone on your same level. And then the programs are going to vary depending on what your target and trigger is for activating peer support, and then how you reach out. And that's what you'll hear across the panel is we all have slightly different variations of our programs, and that will decide, like, do you reach out to them? Do you have people reach out to you? So everyone's gonna vary. And so if you're doing peer support in your program or your institution, the amount of confidentiality that's involved will vary, but it's a huge issue, right? So do people, like, is it both at UVM and, I was at Brown before. And so a lot of the emphasis there was about normalizing seeking help, that we have difficult cases. And for both places, our trigger is difficult cases, and basically like the ones that people are like, did you hear about that case? That's the trigger. And it doesn't have to be that you only talk about that. We're really about trying to build culture so that you check in with people and they may say the case didn't matter, but the divorce I'm going through really matters, or the fact that like my 3-year-old doesn't sleep has made me really testy, and now I wonder if maybe I could have thought better. So it's about creating culture within our department. If it's an institutional wide intervention, it's not going to be on the same level, but whatever the intervention is, confidentiality is huge. And then confidentiality also, like in terms of the people you're reaching out to, but then also in terms of the case itself. So that's one of the questions that always comes up in the trainings, is discoverability. And it's something I think all of our programs address directly or indirectly. We, at our program, because it's case-based often as a trigger, you don't have to talk about the case, but we talk about talking about the feelings rather than the facts of the case. And the expectation is not that you're going to be like, tell me exactly what happens, and really coaching people to figure out how to redirect people to some degree. So you're not just hearing patient so-and-so, who we all know, who's 35 years old, right? So that you're getting more confidentiality, and then you're protected. And there's lots of ways in which this is a somewhat protected process. And we can talk more about that in the panel discussion if people have questions.
Ella in the corner, do you want to talk a little bit about how you do your referrals at Stanford?
Yeah, I think you've heard a lot about opt-in versus opt-out. The way that we do it for the peer support program, so there's 4 different versions for us at Stanford. And the way that we do it for the peer support program is that we actually have them opt in. And the reason for that is specifically because a couple of years ago, as you can imagine, this is the whole institution, and a lot of the stress really, there's the patient outcome that's driven, there's family issues, but also litigation stress. And so a couple of these cases that we worked with our risk management, when we reached out to them proactively, what we realized was a couple of them were like, how did you know about my case? This is supposed to be confidential. And so you can imagine people are like, yeah, that's right. Like, how do you then navigate that? So currently, actually, we're investigating a different approach to doing that so that we still give them a chance to like opt out, that hey, we understand that this process is very challenging. Here are some support systems, but right now we are opt in. I think it's also important to try different approaches. So within the PRN program, we have proactive processes. So anesthesia is a great model for that, modeled with Joe Shapiro's, wherein what they do is for every case that they have, before they can even sign the chart, the final attending signing the chart, they ask the question, is there a quality concern for this case, or is there a possibility for a reach out for peer support? And by doing that, every single case is then having that lens of, can we provide some support? You can imagine that requires a lot of training, a lot of peer supporters, and creating that system like 24/7 is not an easy thing. So for me, for the program that I run for the entire School of Medicine, it's not going to be sustainable to do that, especially with one person running that. So we have the proactive. We also have the opt-in parts of it.
Well, and I think that's a really good point too of why do we talk, the opt-in, opt-out is a big thing within well-being. Like if you look at research for well-being, because there's lots of barriers, particularly with physicians, they're the ones that report the most barriers. And to LA's point about like this iterative process, like I've done this at 2 different institutions and the programs are not identical because each group is a little bit different, and it's whether or not it's an institutional intervention. but it also needs to be somewhat grassroots, like it's kind of working on both levels. So, for example, at my current institution at UVM, people reach out to me. I've tried different things. I had like an administrative assistant reach out to people thinking that would be a lower barrier and maybe they'd feel intimidated. And actually, they said no to her every time. And the first time I called, I was like, "Well, we're doing this program." Like, "Oh, sure." Like they immediately like opted in, and I was like, "Okay, we just need to shift this." So the way we work, deal with referrals is we have a smaller department and everyone knows me, so they literally text me because they know I function better that way. And they say there was a rough case yesterday, and I can either research like what happened. They might say so and so was involved. Often it's the attendings will reach out to me and say, "Can you reach out to the residents?" And then I reflexively also reach out to the attendings. And so it's really everyone involved in the case who's at the level of that where we have peer support. We have peer supporters that I'm part of for the APP's residents and attendings. And then I pair with two different people of our trained peer supporters. We have like 30 peer supporters within our department. And so I normally reach out to two people and say, "Hey, would either of you be willing to reach out to this person?" That allows one of them, if they know them better, to say, "Hey, I'll take it." And I try to pair people that I already know that I think might be a good fit. But I try to leave a lot of space for goodness of fit, and that is going to be a building environment as opposed to, "I don't know that person at all. I don't want to talk to them about my personal feelings." But that's going to differ institution to institution.
So we've talked a lot so far about having peer support when you have tough cases, okay? And Dr. McPeak alluded to it before, that there are other instances besides tough cases. And I would like to say, probably most of us in this room would benefit from a peer-to-peer supporter, because with all the other big bucket is, so this, you have this tough case, and the other big bucket that we're all going through, maybe we don't have a tough case, but we are all having moral injury thrown in our face every day. We're all feeling burned out. We're all grieving for something that should be good and it's not good. And so, so when we train nationally, that's what we're training for too. So we practice with a tough case, but we also practice with this nebulous thing like, well, I don't feel good about emergency medicine. Should I leave? Should I stay? You know, I'm so angry at my administrator. I'm so angry at this. I'm so frustrated. I feel ashamed. Those discussions have to occur also. And I challenge you, if you're not doing that in your department or in your program, to somehow try and figure out how to fit that in. Because I can tell you, I've done some informal peer support where I've needed it. So I've called up somebody that I know, say like in the Midwest, and say, "Did you want to hear what happened to me today?" And I just need to sort of get it off my chest. And once it's out there, I feel a lot better. So just something else to consider.
Sure, and I can amplify many of those points. I want to start also by saying, for those that are thinking about starting it, or perhaps have started it and it's still small, a lot of what we're talking about, I just want to acknowledge we've been at this for a while. So it really does evolve and it grows and it gets to the point where you can cover many more of the bases. Our program started very much about the headliners, is what we called it, which was alluded to, you know, the bad and the sad, kind of the objective cases where it was so dramatic that it was obvious, I'm putting in quotes, that someone might need support, and then really just morphed to being everything, being the moral injury, being a death in the family outside of work. I think the culture change that we've alluded to and really named is how it gets embedded as often a first thought. So if someone is acting out on a shift, instead of thinking that behavior change is maybe them being a not nice word, perhaps they're struggling, right? And instead of writing someone up, perhaps the benefit of the doubt of wondering kind of why it's different, we get referrals for that a lot. And those are really nebulous, but you figure it out. We have, I guess, a little bit differently also standardized the triggers, which people have talked about. So we have where you can request for yourself, you can refer someone else in, which I think is very powerful. And you talked about with the residents. So if you're the intern and you're really worried that the nurse is clearly upset, but maybe you don't have the social capital or the bravery to say like, hey, what's up? You can send their name in, and we've never had anyone be like, who told you to reach out to me? Because we just call, right? And we're calling as a peer just to say everything is hard. We heard some stuff happen. We heard you're struggling. What do you need? We've also built it in that all of our root cause analysis or bad event risk review, whatever your wording is for that, they all get referred to us. The incidents in our reporting portal, they all go to Helping Healers Heal. So every incident of workplace violence against staff that's reported, they all come in. That's really, I think, the culture change of normalizing it, because then no one says, I thought it was confidential. It's just a way of life at our institution. You know someone will reach out. And we hear from lots of people, and there are studies that support it, that even if you decline and you say, I'm fine, and you don't want to talk, which no one's fine, right? So that's nonsense. But even if you decline it, because maybe you have your own safe listeners and support, there's actually just a lot of support in being at a place that has a culture where it exists, where you know the option is there if you were to reach the point where you wanted to accept it. But it is an evolution based on need. And COVID, the gray lining, I think, was it really leveled the playing field on normalizing the need for support.
One thing that I'll just add, I think, is that it's important to recognize that these are like 1 or 2 sessions. This is not like a longitudinal commitment, like very clearly delineated. For me, like for our role, it's like that's why the training is very important. We're training them as like coaches more and less about like you're fixing the problem. And also for me, one of the things that we really specifically look for is we look for those people that other either colleagues or department heads would say like, hey, check out Sadia. Sadia has done a lot of work on this. Like she'll be a great peer supporter. The reason for that is that many people will carry baggages as well. We're in a very fixing environment. And so if you like my sense is that the people who tend to volunteer to be peer supporters, they carry agendas as well that are not as helpful actually to supporting colleagues who are in distress. And so we're very clear about like making sure that the training is focused on the coaching and less about the fixing part.
Totally. Yeah. Great point.
Laura briefly touched on this, but do any of our panelists want to talk about how you match peer supporter to peer supporter at your institution? Any power dynamics, hierarchy that might occur?
I can talk about it. I would say there's a huge amount of discretion that comes into it because much like Ellie's kind of bringing to light, not all peer support champions are created equal. They're never going to have the same skill sets or comfort levels, and you want to know where they're at before you're dispatching them to something. So I think a lot of the matching really comes down to what is the trigger for why they need support, and then who is the person, because there are power dynamics. And, there's some things that I think on paper are pretty obvious, might not be fair to the person or the peer supporter. You're not going to send, an intern who might be an awesome peer supporter, probably to be the peer to your chair, because it would be uncomfortable for both. This may be slightly unpopular against what some people think. I think maybe not the chair. There's a lot of power sometimes in having someone higher up be the peer to someone lower, because it can offer a lot of permission. When someone that is very respected and more senior and at it a long time can sit in the proverbial shit with someone who's more junior and show up as a peer, it often can give them permission to really know that they're not the only one, and kind of to see that everybody is struggling, no matter how we all show up, right, with our shiny, brave faces. But I think a lot is discretion. And if you're sending someone after a bad event or something that will clearly become potentially a legal case, again, you want to also use some discretion on who are the peers that you trust them all, but that will, potentially show up the most appropriately to handle it based on what it is. So that alone is a process, and I think more of an art than a science.
We specifically have ours, and I know we had this like variations in this group. At Stanford, you're paired outside of your department because it's very common. So, for instance, like if I support somebody from OBGYN, they can talk about like their chair that they don't get along or whatever else drama that's happening there. Then if you talk to a peer within your department, then it's kind of like, but I know that person, and how do I then navigate this? Now I know something about you. So we intentionally in our institution pair you outside of your, which is harder for emergency medicine because we interact with so many different folks, and so then we have to be very creative in making sure that they don't know each other.
If I could just build on that too, I would say a lot of times we just ask people what they prefer because they will already have, a preset notion of what they would like. And that goes to what was said earlier, that having options, I think Rita said it, at another institution is something that we do and feel very strongly about, because some people will maybe only be willing to talk to someone they'd never run into in the hallway. And I like to think also of, don't pair someone with a peer that's someone they would get support from anyway, as the easiest way to sum up. If it's going to be a close peer in the same department, get them other additional support. Let them have that too, but let this be a kind of a different interaction.
And this is sort of, oh, go ahead.
Oh.
Yeah, this is sort of at odds with what the data does show from the National Alliance for Mental Illness. It does show that emergency physicians really want to talk to other emergency physicians. So, there are, like we've just kept saying, there are just a million different ways to do it, and you've got to figure out what the culture is in your own department.
We try to do our best at UC Davis to match the peer responder, but one of the things that we have to emphasize is sometimes when we pair physician with physician, it doesn't necessarily have to be of the same specialty. So especially for some of you who are starting out with a new program and might not necessarily have like peer supporters of every specialty if you want to implement it institution-wide, like for such situations, like it might just merely be the shared experience of being a physician that might be enough for the matching. Because as far as the specific situations, like when we deal with, say, for critical incidents, it's not so much about knowing exactly what happened as coming in as a peer supporter to help with the session, but it's more about being able to offer the support, and having a little bit of the shared experience as a career background helps. And the emphasis isn't about as opposed to root cause analysis, like exactly what happened, but it's more about the emotional support.
Thank you all. That was very helpful. I know I learned a lot from that. A whole nother talk beyond the scope of today, the peer support conversation, like how do you learn to frame these conversations appropriately, respectfully, and have somebody feel like they're heard. In that resources QR code, there is a link to something that Susie's group actually has worked on to help train individuals. And oftentimes these are multiple hour-long trainings to really get peer supporters up and running and ready to have these conversations. All right, our final question for our panelists today. How do you make a peer support program long-lasting and sustainable? Maybe you can frame some of your conversations around how long the peer support program has been at your institution as well.
I mean, I can start off with just saying at the institutional level at Sinai, we have the eye care program that I was referring to. And I think, people need to understand that you can always start on a smaller scale. So the idea here being, obviously, at the institutional level, we do need to have the key stakeholders at the table. You need to obviously get the C-suite blessing, but that's at the institutional level. If we're talking about departmental level, obviously, the chair and others have to be on board. And I would say that even all the leadership lines, so PAs, NPs, your nursing staff, the ancillary staff. The key thing, though, is I hope that people who do not have a peer-to-peer program don't get overwhelmed by this, because you can definitely start on a smaller scale with the resources that you have and then build from there. Obviously, finances do come into play, and I think maybe Ellie, you want to share what you've been doing?
Yeah, so for us, we actually don't pay the peer supporters, shockingly, and that's kind of a tough question, right? Because then why are they just volunteering their time? I think that for us, it's important to understand that unlike the many big programs that we have here across the table, the utilization of peer support actually within our institution is not that high. And I know this across the country as well when I speak to other peer support programs, because again, there is that sense that like people are finding some sort of support with their colleagues. I think it's just important to differentiate. Like there's some role for venting, but the helping people actually process and feeling that the experience is normal. That's what peer support is for. So for us, the program director for the peer support program, there's a stipend for that to be on call pretty much like 24/7 for the entire year. And short of that, everybody else, you really are asking them to volunteer. What I do is I ask them to re-up every year because that way you don't feel obligated to be the forever peer supporter. And we also understand like seasons in people's lives, and so there in the summer months, like I know certain people are not going to be available. What is important though is that the institutional support. So I get an administrative support that collects the data that makes a lot of these resources available, and we meet with the C-suite every year, twice a year, to make sure that this is protected. In California, it's 1157 protection from discoverability, so that any conversations that we have with whoever we're supporting, they can't really subpoena us. And if they do, I'll just tell them that I have no idea. I don't remember what we talked about because I always talk in hypotheticals. So those are the kinds of things that we do, I think, from an institutional level, and from a financial level. We're able to develop different tiny programs because we're piloting different ways, proactive versus reactive, and having one person kind of oversee the delivery of this.
And although it may seem obvious, no notes are taken ever. Anytime, no recordings.
I'm just gonna add, I think we're fortunate at Brown to have a grant for our wellness and peer support program. So we have small stipends that we give our peer supporters, which we kind of went back and forth on whether that was a good thing or not. All right, we finally kind of landed on just the importance of using that stipend kind of as to say that we value people's time committing to this. And it, I think it allows people to feel more bought into and committed to the peer support program. But even before we had the stipends, people were pretty like willing and interested in doing this because they cared about being a support for their peers. But I think we are also very fortunate to have support throughout our entire leadership structure. And so I think that helps both on the resident side. The residency leadership is really great and proactive about referring residents they're concerned about. And then on the Brown Emergency Medicine physician side, we have got great leadership and support there.
At UC Davis, we have financial support for our leadership in the for the peer support program, which includes Katrin right here, sitting in the audience. And then as far as among the peer supporters, we hold quarterly meetings as check-ins for people to be able to give each other support, as well as annual trainings for the peer supporters, which includes like refreshing skills as well as teaching new skills. And then also we just keep on doing periodic recruitments with and doing new trainings.
And Andrew brings up a really good point that this is like CPR. You've got to keep training in it or you're going to lose your skills. You're going to lose that ability to be able to have those really serious conversations with people and be able to, reframe their situation, be able to have empathetic responses right on the tip of your tongue and not just saying, oh, I'm sorry this happened to you. I'm sorry this happened to you. It can't. So you really have to practice.
And I would say similar to what I said before, I think these things evolve. We started completely volunteer peers many years ago and ran that way for a while. It was truly a labor of love, and people that were the most invested in it put the most time into it. I think as it's evolved, and again, this is hospital-wide and system-wide for us, so paid infrastructure, our peers are still volunteers, but having some like super peers, kind of, for lack of a better term, that are paid, it allows you to grow. So if you're intentional in the scope that you want to have and how much reach you want to have, as we talk about, culture change and embedding this as something that's never going away, I personally think having some paid infrastructure both shows the institutional skin in the game, as well as it really just allows you to do more and more. And if you want to do crisis response, you want to have people, on call that show up faster, staff different things, you need to at least protect their time, if not, outright pay them. But again, that comes over time. None of this necessarily has to be done or starts there.
I'll touch upon what Andrew said as well, which I think is very, very important. Just like when we take care of patients in the emergency department, there's a vicarious trauma that happens. We take in some of that, right? And so important to this effort is to have support for the supporters, because some of the things that you will hear will be really like horrific. And I think it's just important that we're also kind of trained to support each other. And that's something that we're able to provide in our program.
Yeah. And when we talk go ahead. No, go ahead. No, I was going to say, when we talk sustainability, I think that's probably one of the biggest points, is supporting the peers, because they just absorb all of the trauma, right? And we don't want them traumatized. So these meetings, these recurrent opportunities are for them to also get support and process it.
I do want to make sure we have enough time for any questions. I'd like to thank all of our panelists who really shared their individual experiences at different institutions, but I think are really applicable to bring back to your home institutions as well. Here's that QR code again, if you didn't catch at the beginning, which has some of the resources and references that we talked about today. And I'd love to open up to the group if there are any questions for our panelists.
As you're formulating your question, I just have to have to say a big plug for this. This is one of the most rewarding things that I get to do, because like we take care of patients, but taking care of each other and our folks, when you see them actually like doing better afterwards, it's so rewarding to watch. I think, Will, that's number 2, so I'll turn on my number 2.
Hello. Hi, everybody. My name is Will. I'm currently a third-year ER resident at Denver Health. Thank you all so much for your expertise. I had a couple of questions. The first one is for your peer supporters. Like you said, some of them have a stipend. I was wondering if you can give me an idea of what that kind of stipend range looks like. And then the second question around like building sustainability. Are there any like quality measures or metrics of success that you utilize to kind of like, make sure that your peer support program is doing what it's intended to do?
I can start talking about the stipend. We have a $500 a year stipend for the residents, APPs, and attending. So it's just based off of a grant that we got, and that was kind of the allotted amount. And then we have some money as well that can go towards trainings, and we have like a couple of times a year we have a like meet and greet. And then the second question is, we do collect some data on just like a form that each peer supporter fills out after they've met with somebody, to kind of say if that person even wanted to engage in a further conversation, if they felt like they had any other needs. So we have some data collection, something we've struggled a little bit to find a balance. Like, I don't want it to be a burden on people, because I want the goal to be just to have the peer support, but it also is nice to have some objective data. But I think one of the most effective things that we have done in keeping this going is that amongst our residents, we have automatic check-ins after difficult rotations. So like after ICU months, and after everybody does a month in trauma, or a couple months in trauma their second year. And so we have these automatic check-ins built in with those, so that even if there wasn't any one case that was terrible, like the residents know that, first of all, there was something terrible that happened, because it was an ICU month, and like, if nothing else, they're just exhausted. And so these check-ins have kind of been built in, and gotten really positive feedback from the residents that they feel like this builds community amongst them, and lets them know that there's somebody they can like talk to, and kind of debrief just about the like general exhaustion of that kind of work.
Hi, I'm Kelly. I'm a PGY1 at SIU in Springfield, Illinois. Thank you again. I can only assume that some instances where people reach out for support or you reach out to see if they need support, maybe you feel like it's above the level of the peer supporter, whoever it may be. Do you have any sort of like infrastructure built in for further referrals if you think that they might need something more than just 1 or 2 sessions?
So that was something I was concerned we didn't hit home enough, but we talked a lot about. I think it's important to see peer support as like the secret weapon for culture change around support. So breaking through the stigma that maybe you'll talk to a peer if you wouldn't talk to a professional, really normalizing the need for support. But I think a big role of the peer supporter is to be the bridge builder and the conduit to get everyone, in my opinion, everyone into professional support. So when we talk sustainability and setup and stakeholders, I think a big piece of that is your behavioral health system and your plan, because there are lots of encounters. We could tell stories, I'm sure, for days where things seem fairly benign, and then all of a sudden there's active suicidal ideation. Or it's really horrific and you're planning ahead for that. How do you get them in? All of us, have very established structures for referrals, and that looks a lot of different ways. But I think it's irresponsible to not do that proactively before you're setting up your system and you find yourself in that. So we actually have very prescriptive crisis pathways and plans and agreements with professional colleagues for what we do for distress. So I'm glad that you highlighted that. But a lot of people won't necessarily want a mental health referral after something happens, but when they look to you as a peer and you're in it and you can commiserate, right? Because it's not therapy, it's a bi-directional sharing. Maybe you say, I'm in therapy because we all should be. And they're like, oh, if that person's in therapy and they're struggling, it's not just me. Well, then yeah, maybe I will take that resource list, or maybe you can make me an appointment. So I think that's a lot of the power of it. And I love that you brought that up, because planning ahead is very emergency medicine minded, but also, how do these things go south? You never want to end up having a peer, that doesn't understand the plan, if that were to be the case.
Yeah, I have the lawyer's number in speed dial. I have like the psychiatrist's number in speed dial. Things like that will come up, and I think it's just very easy to just connect with them and having that warm handoff.
Yeah, it's a great question.
I would also be remiss if I don't acknowledge the work of our administrative staff. Like, they can be really powerful in the department to actually providing that lens of, hey, you might want to check in with this person. And so I know, I see Bianca over here. Like when I was an APD, like she would be able to notice when I am tired, and she'll like, are you okay? Have you slept well? Or she'll actually say something like, hey, you might want to check in with this resident because I noticed XYZ, because people are more likely to open up to them than to, again, the faculty on some cases.
I'm actually sort of curious to know how many peer supporters you guys may have, because we see terrible cases in the emergency department every single day, multiple times a day, right? So I'm thinking back in January, we had a case of a pregnant woman who was involved in a terrible trauma and ended up with a perimortem C-section, and both she and the
Hypothetically,
baby
of
died.
course.
There were tons of people involved in this case, right? The whole trauma team, OB, pediatrics, emergency medicine, attendings and residents, EVS, nursing. I mean, there were tons of people involved in this case. And even if we forget, and EMS, and even if we forget everyone other than the emergency department staff and like the EMS people, there were probably 15 people involved in this. Yeah. So to reach out to each of those 15 people, even for a one-time conversation, takes a tremendous number of peer supporters. So I'm kind of curious to know how that practically works in your departments, how many people you have available to do this, how much time they plan on taking on a regular basis to do this work.
That's why we also opt in for ours, because once you forget one person, that one person will feel really left out. We tried that pilot in the emergency department when we work with our trauma service. So any deaths in the emergency department that's trauma related, we would abstract with an abstractor that would look at the chart, any techs, nurses, respiratory therapist, social worker, everybody, residents, faculty. If you miss one person, it was really heartbreaking because then you don't mean that but at the same time, they feel like they were left out. I didn't answer the question.
Not entirely.
yeah.
I think it gets into there's different models and it depends. And like I said, we have some paid, which gives us more bandwidth, but we've evolved to that. We do a lot of, in that case, if someone it's happening because you get the red trauma alert, whatever else. If we have a peer, we'll have someone in the department after to not necessarily do it in that moment, but diffuse, acknowledge it's happened, remind everyone the program's there. And we also do a lot of, we call it commiseration coffee, but just going as a peer, like instead of a morning report case, and just sitting and being like, what has happened in the last week or whatever, how are things been? Sometimes those cases will come up. Sometimes people want to talk about other things, but, just generalizing that everything is hard all the time, be it anchored to a case or not, I think lets you also reach more people. But that's about just saturation and integration and making sure you get to a point you hope where a lot of those people will reach out, because they'll know the program is there because it's just embedded and people are sick of hearing about it. That's where I aim to be, is people are sick of me talking about it. We're there.
I think all the time we have. Thank you all so much for coming. Thank you to our panelists again.
Thank you, Vicki.
Thank you.